So we thought we would just quickly whiz through the key performance information for the Trust. But my sense is there will be a lot of questions about what is going on in the future of Epsom and St Helier that you will want to ask about. So we will try and leave 40 minutes for all of that. So let's see if we can get through all the performance in the first 20 minutes.
Shall I start? Yeah. So as usual, I'll start with the safe domain. Key headlines from the report are that mortality rates remain low, top quartile in the country, which is a very pleasing position to be in, but one that we are not at all complacent about, and lots of further work going on in that regard. We're still struggling to ensure that all our VTE assessments are done in a timely way, and have put in some more changes and monitoring through our ward huddles and whiteboard system to try and focus on that. And then the final point, I think, to flag up that we haven't really picked up on before is you'll see the measure that relates to incident reporting and duty of offender. Because as a learning organisation, we actually want to have incidents raised, investigate them, and be open, honest and transparent with families. And we've got a very rigorous process in place to enact duty of candor, which we're actually complying with exceptionally well. So the teams have done very well in that regard.
Thank you, Ruth. I should have said Ruth is the Medical Director and Deputy Chief Executive.
I'm Charlotte,
Chief Nurse. So we're consistently performing well on our preventing harms to patients, and actually we've seen a good reduction in falls, and also this last month, morning deaths in grade 2 pressure ulcers, which is really pleasing to see. Our staffing levels have remained stable and consistent. We're managing to keep that safe. On infection control, I'm very pleased to say it's been 100 days, I mark things in 100s, since we had an MRSA bacteremia, which is good for us. So I'm not complacent, shout that. But I want to say, and our hand hygiene compliance has improved very, very much so in the last 3 months. The maternity one-to-one care continues to be high. That's because of the success we had in recruiting extra midwives probably about a year ago. We're really seeing the benefits of that. I'm just going to cover Tim's part as well, because Tim is our patient experience. He's on annual leave today, I'm afraid. But we've had a rolling programme with our ward managers to interpret the friends and the family feedback that we've been getting, and they're far more engaged with that now. We've seen marked improvements in the scores. A&E recommended score is down at 85%, but actually the numbers of responders from A&E is much better, and we're doing a bit of a deep dive into what is making causing that to go down. Health Watch have done a very good piece of work on the Sutton side with us. We've hit all our wards, and we're going to do, Tracy, my colleague over there, is going to lead a piece of work later this month with the ward managers and Health Watch feeding back. You said we did. So, Caroline.
Hello, my name is Caroline, I'm the Chief Operating Officer. We're one of the few trusts in the country that are consistently delivering for ED performance standard, and we are regularly #1 in London, which we're very proud of. And despite a very challenging winter, we are still on track to achieve 90.5% of the whole year of our patients being seen within 4 hours. I'm proud to say that we have consistently achieved our cancer access targets for our patients. The 18-week referral to treatment target is still a challenge for us, but we have very robust plans in place to ensure that we will be delivering in the next financial year. The December blip that I had to report last time around our diagnostic performance has now been addressed, and we are on track to deliver our diagnostic performance.
And then on workforce, so our vacancy rates in the non-clinical areas are high, and that is deliberate, as we are trying to reduce the amount we spend on non-clinical staff. But we are on track in maintaining the numbers of clinical staff we have in the organisation. And we will be one of the only trusts around us that achieves the reduction in agency spend that we were set, which is a 30% reduction in the year. And then on the money, as at the end of January, we are still on track to deliver the planned deficit that was set. and we are the only trust in South West London that is on track to only deliver the deficit that they were set. Everyone else's deficit has got worse. So that is a relatively good news story too. And you will see that if you look at the month 12 finances, so the prediction for March is a very big surplus. And that is because we are anticipating, just looking at Councillor Alley, that Sutton Council are going to purchase a chunk of the Sutton site this month.
I put me on the spot.
So that's it in terms of an overview of the performance. So it's a good place to start. Are there any questions on any aspects of the operational performance you'd like to talk about?
If the staffing level is steady, staffing level, what's the ratio of agent staff to the permanent staff?
We use very little agency nurses on our general wards. We do use agency nurses in A&E and intensive care, which is where we have biggest numbers of vacancies. So we have a very good staff bank, and 60% of our staff bank are our own staff. They choose to do extra shifts. So on a day-to-day basis, as a sort of rough finger in the air, I would say probably about 15% of our staff are bank. But as I say, we use very little agency in our general wards because we've done well with our recruitment. But recruitment's always a struggle, and we continue to keep being very proactive about it.
So we'll just go here and here, and then here's while these questions have been asked, Bob's written us a list of very good questions, but we'll wait for him to come back. So Liz?
Thank you. You were saying about the high vacancy rate in the non-clinical staff. Is this going to impinge on service? Because I get quite concerned that sometimes you cut things like that, and then there isn't the backup for the staff, and you have problems with the efficiency of the services. So could you just explain, please, how that was going to be kept safe?
So it will have no impact on patient care. And if it had, you would have noticed already, because it happened quite a long time ago in this financial.
Okay, yeah. So it's not just something new. It's been like it for some time.
Yeah.
Okay, thank you.
The ratio of qualified staff who are full-time to agency staff, is that maintained on night duty as well as day duty?
Yeah, we have set staffing levels for days and nights, and our staff all rotate. So on the general wards, in the main, broad brush speaking, we'll have 3 registered nurses and 3 healthcare assistants on our general wards on night duty, and we always keep that level. We never deviate. In fact, it's often be bolstered if we've got some very sick patients. We don't have a particularly high number of permanent staff wanting to do nights, and all our nurses rotate through. So, and as I say, 60% of our bank staff are our own staff, so we know them, and we put them through the bank internally. We never leave agency nurses that are not known to us in charge of any of our ward areas on nights or days.
Can I ask another question about breast cancer patients? Are you treating all of your breast cancer patients here, or are some of them being referred to East Surrey?
So we don't.
No, we don't do any breast cancer.
You don't. They all go to East
No.
No, they go to George's and they
the Royal Marsden.
Marsden.
So let's do Bob's questions. And the first one we spotted ourselves. So Ruth, here you go. Emergency readmissions. Why have we shown such a large reduction in emergency readmissions?
The performance dashboard I've got here shows readmissions to be steady. So,
but do you remember
there's obviously another version of the data. So our team ran an analysis of readmissions, applying exclusions to readmissions that nationally can be applied. And that was the outcome. The 4.8% was the outcome of applying exclusions. However, the paper should say, the paper I've got in front of me, refers to a readmission rate still using the old methodology, which is, as you quite rightly say, Bob, is stubbornly high at 7.7% and 7.4% year to date. We are in discussion with NHSI, and we'll have a look and see whether we've sent out perhaps the data that's got the exclusions in it in error. because what should be here, because it's very important, as you say, that the reporting is consistent here.
Yeah, no, it's across the year, you know, so it's a bit funny.
Yeah. So what should be in your pack is a readmission rate in month of 7.7%.
So it says, what does it say? Oh, readmission.
So
4.4 is it?
yes. So the story of our narrative.
It's okay. I have raised the question.
Yeah. So let's be clear that you understand the answer.
Yeah.
So the way we were calculating our emergency readmissions was a bespoke way that Epsom St Helier has always done.
Yeah.
Okay.
And when we were trying to look into this looks really high, we have tried to find out how is the national metric calculated.
Okay.
And the national metric is calculated differently to how we calculate it. So then we applied the national metric and it showed it came down.
However, it's going to change again from April.
Yeah.
So we're being in touch then with NHSI. So we want to be presenting equivalent data to other trusts. And and we're aware that from the 1st of April, the oversight framework that NHSI used to monitor trust performance is now going to include readmission rates for all trusts. Now, so we've gone back to them and said, can you tell us the methodology that you're applying? Because it's that methodology that we need to be using and presenting on our scorecard, and it is still under development.
Yeah.
Okay.
So that's what we will be using from April, but you're absolutely right, our readmission rate has not changed. It has not changed miraculously, it is the same. But if we wanted to present it differently using exclusions, we could do, but we're not going to do that.
But the figure on the left hasn't changed. So the figure on the left, 5.8, the limit.
When we posted the papers up on the website, it did have the incorrect figure in, because I think you print them out from the website, but the version circulated here has got the correct figure in.
Oh, you can't expect me to do that. Here you are, you weren't there.
So we're a good spot. So I hope you now understand.
Thank you. Okay, it's just,
It's a really important point.
an oddity.
Yes.
No, absolutely agree.
There are going to be CQC people, no, it doesn't matter. I've got it, thanks. Yeah, CQC will go through these documents, and so I'm just doing the job that CQC was doing for you instead.
Okay.
Right.
The next one, dementia screening risk assessments. We seem to be getting not so good at. Which of you is going to pick that up?
As well. Absolutely. We've done a deep dive into this to look at the reasons why dementia screening is falling off, and actually are now working with our clinical lead for dementia to see what we can do within current resource to actually maximise the screening rates that are undertaken. The thrust that we're taking is to use the same approach that we use for VTE, and I acknowledge that VTE has just been below the 95%. By actually incorporating the dementia screening, whether it's been done or not, into the ward whiteboard and the ward huddles that take place. So we are doing that because it transpires that the reason it's not being done is we haven't been nagging enough. I'm completely frank.
See, there's a supervision problem somewhere.
It's back to nagging, it's basics. It's back to basics.
Okay.
And by having the whole team focusing on it at the consultant huddle, that focuses minds to actually enhance compliance.
Next time.
Yeah. It probably won't be next time because this is reported.
Okay, no, all right. So I'll give you a month.
But also from April, we won't be reporting it because in the single operating oversight framework that we have been set by our regulator, they have now taken this indicator out. So,
so whether you have it or not, don't you think it's a good idea to keep it?
So from a clinical perspective, we will still be screening patients for dementia because that is part of clinical practice.
Right.
So that bit doesn't
But the clinical
change.
practice isn't up to scratch, is it? So
And the thrust to enhance compliance and to make sure patients are screened continues, but it will be there for clinical reasons rather than as a performance measure.
Thank you.
Then we've got were any of the level 3 SIs in January avoidable?
I can't answer that question yet because of the time frame within which SIs are completed. So as you know, it's usually a 9-week, 45-day turnaround for the investigation reports, and when they're done, as you know, we'll be presenting to the board from April onwards potentially avoidable deaths in line with the new national guidance that's been issued. And so you'll see our reporting change from April onwards, which I sense is behind the question.
So the VTE then, did I write that down?
No.
Oh, sorry, Will, I meant to write. I'm just saying, not as satisfactory as well. I mean, we're so close to the limit of 95, 93.6. I'm crying out loud.
I know.
So we've still got 4 more questions to go from Bob.
Yes,
but
yes.
let's break them up with
Okay, thank you.
David first. Oh, you don't have a question?
No.
Is it, Bess, are you still a question about, we're doing performance questions first?
Oh, no.
Yeah? Okay, so let's carry on with Bob's performance questions.
So I'll crack on. Yes, you're right, about 3 years, touch wood. C. diff, it was getting a little bit high in January, but in February we've had 1, and we're right back on trajectory now. We will be under trajectory by the end of the month. Touch wood. I'm keeping a lot of fingers crossed here.
Postpartum hemorrhages.
Yes, we've started using carbetocin for severe postpartum hemorrhage at Epsom because we think, and at St Helier now, because we think it does impact on the level of postpartum hemorrhage.
But the result doesn't show that.
We've only just started using it.
What,
So
in Epsom?
In Epsom, yeah.
I thought it was being used last month
It was being
as well.
trialled, but now it's used very much.
No, it's all right. It's gone up quite a lot, yeah? And so, are people thinking that because you're using it?
No, I don't think so. We asked the obstetrics group at one of our meetings what's going on, because we noticed that the birth centres had gone down, and the started to come up again now, and that the postpartum hemorrhage wasn't necessarily where we wanted it to be.
Right.
So they've been doing a bit of a deep dive into it, but they've agreed that this drug, which is a relatively new drug, should be used across both sites, and they're doing more deep dives into what actually is the cause of the postpartum hemorrhages.
Okay.
I think the thing is it's such small numbers that
Yeah.
any statistical trend is going to take some months to emerge.
Such small. Yes, but it's funny. See, it's been going, and it's just, I go through it. You know I go through it, right? And
I know
I'm
you-
looking at the
yeah.
figures.
Yeah.
And, yeah.
And then the last one, why have we not got the ambulance delays for Epsom for January?
So I can't answer that. So, sorry?
It's because CCAP haven't sent
Oh,
them.
right, okay. I haven't sent them, so is the answer.
Don't we do it ourselves as well? Don't we do it ourselves?
So
Check.
there's been lots of questions about ambulance handover delays and ambulance information at previous boards, and there is a complex piece of work that needs to be done, because the information that is provided to us by our colleagues in the ambulance service is not the same information that we recognise from the monitoring that we do in the department. So there's a big piece of work to do about where the beacon is situated, because when ambulances enter an acute trust, there's a beacon which turns their clock on, turns our clock on, and then there's a clear time when they clear.
Okay.
We're not sure our data is the same, but I don't want to focus on doing that piece of work in the middle of winter. So the plan is I'm working with the teams in the 2 EDs to really focus on that work once we come out of the winter period. So I hope, Bob, that towards spring and summer, I'll start to have a more concise answer for you.
Don't you? I do not want to see this hospital or St Helier
On the front page.
losing,
Yeah.
because of lack. Well, no, sorry, it won't be St Helier. It's just this hospital.
So our ambulance handover times are some of the best around.
Yeah.
Okay,
So-
but it's not recorded. And if I'm the CQC again, I'm going to be saying, what the hell is this about? Yeah, and it's just something that they get their teeth into. Isn't it?
Absolutely, and that is why we have this piece of work scheduled. But what we want to do is we're very fortunate, we have a very good relationship with our ambulance colleagues, both with LAS and with CCAM. And so we want to work collaboratively with them around that piece of work to ensure that the data that we are going to be presenting represents what they are experiencing and what we are experiencing. I'm absolutely on it, Bob, because we need to get it right. So I appreciate
it's
your
all right.
candor around it.
Yeah. No, I'm not cross, I'm just...
No.
Councillor Crosses?
Yeah, it concerns me that you're putting it off until you get out of the worst period of the year. That's hiding things a bit, isn't it? Surely you should start it when things are at their worst and then run it to when things get a bit better, but not to put it off because you don't want to do it in the winter.
So I can sit here and absolutely assure you that we do not have an issue on this site or St Helier with offloading patients in a timely manner. We do not have patients queuing in our corridors to be offloaded. What we do have is a challenge around the data and the recording, and are querying around the situation of the beacon. Now, I could focus time on doing that now, but that would take me away from the work I'm doing around the emergency pathways to ensure that our patients do get offloaded from ambulances quickly, get triaged and get seen within 4 hours. I think that's more important at the moment. We are absolutely not trying to hide anything. In fact, what I think we're trying to do is prioritise how we care for our patients.
That's the answer.
This is the question you would expect to be asked, isn't
Absolutely.
it? Yeah?
Yeah.
And if we don't ask that question,
No.
we're not doing our
No.
job sitting this side of the table.
No. And you've asked it in previous boards, and I'm on my toes around it, Bob, I promise you.
No, you know it. I go
Yes.
down the line.
Okay.
Thank you.
Are there any more questions on anything in the performance report from anybody? Okay, let's go for wider strategic context questions, of which I'm sure there are going to be plenty.
Can I start then?
Yes.
Well, I've got actually three. South West London, and I'm talking as a councillor, Reigate, Banstead. Liz knows as well the problems. South West London are advertising, in the press, continually saying there's one hospital going to have to shut out of the 5. It's reared its head once again. I, as the executive member for health like Liz is, I'm continually getting people saying what's happening with Epsom Hospital, because the north of the borough, Reigate and Banstead, comes here. So what is actually happening? Because South West London is still pushing it, that one hospital is going to shut. Do you want to answer that first before I go into the second one?
Are the two others related, or are they?
No, the second question is, we're hearing that these 44 STPs are going to be the saviour of the national health throughout the country, with far more collaborative working, which I agree with. There has to be linked up. We're doing it in the council. I'm sure you do as well. The King's Fund announced very recently that unless the STPs had an extra £10 billion funding, they wouldn't be viable. And the STP have got no B plan. That came through on the National Health Executive only a couple of weeks ago, that they won't work the way they are supposed to work. Right, my third question is, both Liz and I are the champions for mental health for our boroughs. You've shut, or they've moved, I know it's not part of you, but the 2 wards have now moved temporary before they go to their proper place. I'm part of Surrey Borders. We're supposed to have had a mental hospital opened up in Redhill. Then that was closed the idea was to have one. Then that was stopped. Then that was reared again about a year ago. And now that's been stopped. We do have a big mental health problem around here, and it's getting more and more. We are working with the schools, especially with the youngsters, to try and improve that the youngsters don't have suffer with mental health. What's happening in this part of the world now for mental health?
Okay. I think, should we just gather a few more, and then we'll try and do it as a collective. Bess?
Right, I'd like to ask first of all about stroke.
Yeah.
I've noticed that we don't seem to be included in the STP over Woking. We used to have meetings, but now we seem to have been dropped, and someone told me that we're part of another group. What is happening with the stroke units at both Epsom and St Helier?
Yeah.
And where are they going? Patients going to go?
Okay.
That's my first question.
Yeah.
Why are lots of people being sent to St Helier, outpatients? I mean, yesterday, for example, a lady told me that she came here for a dental problem, and she was told the machine's still broken and she's got to go to St Helier. I understand it's been broken for quite some time. Why aren't these and other bits being fixed? I mean, people are coming to me for the bladder scanner because there are 29 bladder scanners over the 2 sites, and I understand not very many are working. They need repairing. A hoist over in the stroke unit, the whatever it's called, control is broken, and the ECG machine, the thing that goes down, I can't remember what it's called, that's broken. It's going to cost £900 to fix. Surely one of the IT men could do something if they repair.
Just go back to the dental question.
Yeah.
Is that adults or children?
Adult.
Okay. And any more?
And why is outpatients seems to be so empty lately, the last few weeks?
I think people are being seen on time actually. We've done a lot of work on templates, so we're working on those.
Okay. Councillor Ali?
Yes, just a question regarding
Question regarding?
St Heliers site, the dialysis service. There's been some rumours and someone's emailed me about concerns that it's moving and it's going to be privatised and there's concerns about jobs.
Speak up, love.
Sorry.
Can't hear you.
I'm concerned about the dialysis services in St Heliers Hospital. I've had an email regarding what's going to happen with that, if it's going to be privatised, what's going to happen to patients and staff.
Okay, right. That's a good selection to go with. We're going to do it mostly in reverse order. Right. So the dialysis at St Helier. So you know that the renal services in the site are at the back, and they are in some of the worst buildings on the site. And we have a plan to move all of the renal services from the back of the site into the main buildings. And the first service that's going to move is the renal dialysis service. And it's going to move into where the restaurant currently is, which is the most perfect place to put the dialysis unit because it has lots of patients who come by ambulance every day or patient transport, and there's a car park right at the front of the hospital that we can use for drop-off. It is going to be considerably bigger than the facility that it is replacing. The spacing between all the dialysis chairs will be infection control friendly. There will also be space to have a part of the renal outpatients clinic in that facility, and we have built it to have more capacity because St George's have not got enough capacity for their dialysis patients, so we will take some of the St George's patients to it. The funding for building it is coming from a company called Renal Services Limited, I think is the name of the company. But all the staff will be employed by the NHS as they currently are. And the reason why Renal has worked like this for a very long time, that you buy the consumables for the dialysis, and in part of the price for the consumables is the cost of the building. And it's nearly all our dialysis units are funded like that, and this will be no different. But it is still NHS staff providing NHS care to NHS patients. It will just be in a much smarter environment, and will be helping to secure the future of the main buildings of St Helier. And the restaurant is moving to the first floor of Ferguson House. And they're also, so that's not as accessible for the public. So we are putting in another lift so that there is a lift that is wheelchair compliant in Ferguson House. But we're also expanding both Costa Coffee and Subway to the ground floor.
Thank you.
So that should be a good news story. It's a many £1 million investment. On the issue of bladder scanners, so we know that we have an issue in repairing bladder scanners, and we are working on getting a maintenance contract that covers all the bladder scanners across the trust, because currently everyone's ordered them separately, and they've all from different manufacturers with different maintenance contracts, and we can't keep track of them. So we're doing a project to put all that together.
There used to be a workshop, you know, Daniel, where the men did all the repairs, didn't they?
So we still have that at St Helier, yeah. So the things we can repair, we do, and the things that you can't, because they basically got full of microchips in, and you know when you take your car in to be serviced now, essentially they plug the car into a computer, and the computer does all the diagnostics. Well, if the companies won't give us those computers, you have to buy the maintenance contract from them, and they have to service it themselves. That's.
But the repair shop is gone. It went a few years back.
No, it's at St Helier. It's in the D block on the ground floor.
Oh right, I'll investigate.
It's near the mortuary.
Oh well, it's near my God to thee.
Dental outpatients I'm not sure I know the answer to that one. Do we know the answer to
No,
that?
I think it would be really helpful to get the patient details and we can actually open this and formally investigate it. Yeah.
Okay. And now we start getting into the more complicated ones to answer. So, stroke. So you know there was the Surrey Stroke Review, which said that we can't carry on having 5 hospitals in Surrey providing hyperacute stroke services. And when they looked at which hospitals wouldn't be doing it, one of them is Epsom. And the reason why Epsom is not one of them is because we don't have enough people in our catchment, and also we're in the wrong part of the geography to cover the whole catchment of people who have stroke in Surrey and Sussex and Hampshire. So we said, that is okay, we are happy to not provide the hyperacute bit of stroke, but what we want to provide is all the rehabilitation after the first 72 hours and have essentially the same service at Epsom that we have at St Helier. And we went through a process to prove to the people doing the review in Surrey that that was going to be the right thing to do. And it was very hard to win the argument because there was quite a lot of people saying we want no stroke service at all on the Epsom site. But we won the argument, and so we're now moving to the new model of doing stroke rehabilitation. So at some point in the next few months we have to stop doing hyperacute stroke services, and they have to transfer to either Sash, to Redhill, or to St Peter's. And when you look at the last set of outcome data for stroke on the Epsom site, we scored a C. So the scale goes A, B, C, D, E, where A is excellent and E is dreadful. So we're right in the middle for stroke rehabilitation, and we scored E for thrombolysis, because we know we do not have the clinical manpower on this site to deliver 24/7 thrombolysis and meet the standards. And if we had not been doing the thrombolysis, but had concentrated all our efforts on the rehabilitation, we would have been an A or a B for the rehabilitation bit. We are working with the CECG on which hospital should Epsom properly link to. Should it be Redhill or should it be Chertsey? And the thought was it was going to be Redhill, but CCAM have now redone where would they take patients to from Epsom, where is the nearest thrombolysis centre, and it turns out the answer is St George's and St Peter's. And actually less people would go to Redhill than they thought. So we're now trying to change our link for Epsom to be with St Peter's than it was for Redhill. And the good thing about St Peter's is they have 6 consultants already doing the thrombolysis. And if Paneet Kakar, our one remaining consultant who does it, joins their rota, then they can offer the full 24/7 service.
Is the real benefit of that service and what we can't do now is actually our stroke patients being seen by a consultant every day of the week, including Saturdays and Sundays. And that's a huge benefit that the new model will afford the patients.
So then you get on to St Helier.
They used to have this system, telemedicine. Well, the other hospitals, I understand, are still going to do that out of hours. So why can't it continue like that here?
So that system is stopping. That system is stopping right across Surrey. So
I understood it was still going to happen.
So we think in May it stops because the other hospitals in Surrey don't want to do it. And when it stops is when we need to stop doing thrombolysis, because that is the safety valve that we currently have. On St Helier stroke.
So do you stay with Epsom, Brett? Oh no, do it. I'll ask afterwards as well.
So on the St Helier stroke front, there should be no need to change the stroke services being offered at St Helier. However, there is a really big manpower problem with stroke consultants, and there really are not enough. So we currently have Kingston, who don't have a stroke consultant. You have St Helier that has 1, and you have Epsom that has 1 and a bit. And the body that talks about stroke is saying I think we need to review the number of stroke units in South West London as well as Surrey. So we're thinking the thing that we need to do is, can we put all our stroke patients together on one site rather than two? Because then we would have the critical mass of staffing and patients. That would mean that if there ever is a review of how many stroke units there should be, we would be guaranteed to be one of them. And it should be one of the benefits of Epsom and St Helier working together as opposed to working as two separate hospitals. So we're just beginning to have that conversation. And there is space on this site to put all of the stroke patients. And that links to the conversation about mental health. So that building there, Langley Wing, the ground floor of that is where the mental health wards that Surrey and Borders were, that they have moved. And the question is, are they going to move back? So you know that they are about to do a consultation on creating a single inpatient mental health centre for Eastern Surrey, and they will consult on a number of options, where one of them will be the Epsom Hospital site. So when we asked them about what is the space that they need and what would they like, they tentatively said that if they chose the Epsom site, they'd like to have the whole of Langley Wing.
Which I used to have, didn't they?
Yeah. But then they need to demolish Langley Wing and rebuild it, because it isn't actually fit for purpose as a mental health facility, which is the reason why they have moved out. So we have said that Langley Wing is probably the best building that we have on this site after the ones that Sir Adrian White put up. So would you mind if we used it? And they have said, well, if you can secure us another plot of land on your Epsom site, that should we choose that we want to locate our new mental health hospital in Epsom, we could buy, then that is fine. And that is where I got completely stumped at Bourne Hall, and because yes, we do intend to sell land on this site, but our proposal is to sell it to another part of the NHS. Should that be where that consultation finishes? So if you stood up and look that way, you will see a huge amount of empty space and Rowan House, which is not used for clinical services. So that space there, if the mental health consultation says that they would like to build their new mental health facility for Eastern Surrey on the Epsom site, is what we think would be the right place to put it. That would mean that we can then use the ground floor of Langley Wing for our hospital-based services. And the thing that we would like to put in Langley Wing are potentially, let's put all our stroke patients together in one place. And the thing about Langley Wing is it is a real rehabilitation focus in it. So if you go into it, there are lots of courtyards, there are lots of rooms that you can turn into rehabilitation space, and there's a separate dining room, there's gardens, there's gym space. So it does not feel like an acute hospital. So it would be really good for stroke. It would also be really good for moving the new Epsom and York Cottage Hospital beds onto the site, and the Poplars Rehabilitation Centre, and all our outpatient therapies. There is something called the St Kilda's Trust, which is one of Adrian White's charities, and it has quite a lot of money in it. And we have asked him whether he could ask the trustees of that charity, could we use all of that money to refit out Langley Wing to provide all those services. And if we get a yes for that, I'd love to have a conversation with you, Bess, about can the Epsom Medical Equipment Fund do in conjunction with a number of other charities, do a big fundraising initiative for equipment to go into that building?
You won't get a yes.
No, you won't ever get a yes.
You'll never get a yes.
We're an outside charity. We're not connected with the others, and I wouldn't go in. It's been tried before and it hasn't worked.
So I think we'd like to have a conversation with you that says, for the good of the people in Epsom who you're raising money for medical equipment, this would be a fantastic project that would provide some amazing healthcare for the future. So it would be nice if we could have the conversation with you having an open mind about it. So that's the whole saga on mental health and how it links to stroke.
So can you go back to
Can we go back to
building and so at the latest, I have to think about which way around it, Wellbeing and Health scrutiny panel at County Hall. Yeah, there was last week, the week before last, I don't know, very recently. There was a lot said about buildings and people kicking up a fuss, and what you had spoken about didn't rear its head at all from either of the people that were speaking about this. I think there was a chap that was either the chair or ex-chair of the trust, yeah, and the Mental Health Trust.
They were there the last time, yeah, but the information they gave was wrong.
Well, he wasn't talking about, he was talking, it doesn't matter, does it? I'll give up, right? I think for me, listening to what went on, this is a crunch, I think. As far as the patients are concerned, it would be really good for the patients if it was here, because the visitors spend at least half a day going and visiting, yes? Getting there and getting back, and it's expense and all sorts of things. So from that meeting, that's what I gathered, was it would be really good for the patients if they were here rather than Red Hill or St. Peter's.
But the people that were in Elgar and DES, the ones that had moved temporary to St. Peter's, the bulk of them came from that part of Surrey rather than this
Okay,
side.
sorry, this is what was said.
I know.
I don't know. I don't have the addresses. I just listened to what was said.
I mean, it's a very rapidly evolving piece. I think what you've heard this morning is very hot off the press, probably even since
Okay.
the meeting last
Well,
week, actually.
I'm just reporting back what. Then, as far as Epsom niche is concerned, yes, in the Epsom healthcare document that you issued last board meeting,
yeah.
it says that stroke patients are at niche.
Yeah.
Is that the case, or is that a typing error?
No, so currently, in the historic world in which we inhabit, we have a stroke ward on Britain Ward in Langway, and then Central Surrey Health have stroke and neuro rehabilitation beds at New Epsom Newell Cottage Hospital.
Okay.
And we're saying those services should be together in one place, and you could join up to make a single team, and it would be much better. So it is correct. So
No, it's okay. I'm just reading something and I'm saying it doesn't.
So then the first two questions are about the big strategic future. So nothing changes from what we said in 2015, which is we're keeping both our hospitals open for A&E, for inpatient paediatrics and obstetrics until 2020. So we did and the question is, well, what does happen then? So we have been really clear on many occasions that our buildings are not fit for purpose for the 21st century, that we can't be solvent in our current financial configuration, and that we can't provide 24/7 healthcare services because our workforce in the acute services is split across two sites. So we are determined as a trust to find an answer that enables us to keep on providing high quality acute services for the 500,000 people who use our two district hospitals. And the task we are facing is convincing our two STPs, so the South West London STP and the Surrey Heartlands STP, although the Surrey Heartlands STP is much easier to convince than the South West London one, to let us talk to you about what are the scenarios by which we could do that. Because we know that there are some scenarios in which we can deliver some outstanding care from outstanding buildings, but we will require 300 or 400 million pounds worth of capital investments to do that. And until we can have the conversation with our communities about what the scenarios are and see if we can get a consensus from our local communities about what we think the right thing to do is, we can't actually we can't move forward. So all the debate about is it 3 sites, is it 4 sites, or is it 5 sites for South West London is really difficult, because until we can land and say it is at least 4, we can't have the conversation. So when I talked to, I spoke at Cuddington Residents Association last week, and you saying there are currently 5 sites is slightly a misnomer, because we think of ourselves as one hospital that works on 2 sites, not 2 separate hospitals, because we have moved so many services between the sites that they're now only on one or the other, that it feels to most of our clinicians that they're working for one institution that happens to mean that they have to travel half an hour between the sites to do some of their job. They don't work for 2 completely different hospitals. So we're thinking that providing we can turn the best working hypothesis in South West London from 4 sites into actually it is 4 sites and what are the 4 sites, then we can have the conversation that says these are the scenarios that are available. And it may be that what comes out of it is you end up with 6 hospital sites, as opposed to the 5 we currently operate from. So I would love, we are very keen to have the conversation, and I'm just trying to galvanise the system into letting us have the conversation with you. Because until we have that, we can't tell you with any certainty what the scenarios are, and all the rumours keep perpetuating round and round and round that our hospitals are closing. And we can tell you that they're not. The problem is we can't tell the rumour mill that they're not.
I mean, can you not get your marketing people, your publicity people, to speak to the papers? But I know that all the papers like is bad news.
Yeah.
They don't like good news. I mean, we know you're doing very, very well, and your figures are. But it's us that face lady in the other end, that get hit all the time. So what are you doing? You're on councillors.
Yes.
You should be fighting for us.
So my ask of all of you as councillors is to be pressing for the STPs to actually come up with the ability to let us have a conversation with you about what our future could be.
Right.
But having the conversation is
Can we let Liz, I don't know what you're going to say.
I think I'm finding the problem is that we're not getting the communication from the SSP. I was copied into their latest newsletter and discovered there was a meeting the week before. When I went to the public meeting in Woking, we all gave in our details and we were supposed to be told about the next ones. I knew nothing about that. So I think that there is an issue that we're not getting communication. Now, I don't know if there's anything that you could feed into that, please, to try and get communication. It said councillors were invited. Well, I don't know what councillors. I wonder whether it was just Surrey County councillors, but I really don't know.
So this is a bit tricky. So
Yes,
the bits of the NHS running the STP, he's not Epsom and St Helier.
No, but you're at the table.
So we are at the table, and the place where you can, as councillors, exercise your influence is through the scrutiny process. Because the same way you ask us to come and present to you, you can ask the STP team to come and present to you. And I would think it would be very helpful if you did, and then ask them some quite searching questions.
Yes. We tried that when we had the public meeting where we did have, when we had James presenting on behalf of the SVP.
But in Epsom and your council,
Yes.
you don't have the statutory power of the scrutiny committee. So we need Surrey County Council, who have that power, I think, to be...
Well, they have the power, surely.
Yes, and they have the power to ask South West London STP to come and present, which is who you need. Because remember, Epsom and St Helier is a London trust, not a Surrey trust. So Surrey Heartlands STP, who are, I think, actually very positively disposed to trying to create the right vision for the Epsom site that we all want, have to work in the constraints of the South West London system too.
Can I just say, till last June, July, I was part of Surrey's scrutiny, as you know. but then I had to step back because of my role at Reigate and Hampstead. All our meetings with STP were completely confidential behind closed doors.
So those were the rules until October. That
We weren't
NHS
allowed to
set.
talk about anything.
No. So you can, well, everyone can have lots of views about whether that was right, but the rule, the guidance now is very clear that the STP conversations should be happening in a forum that the public can engage with.
Okay, so as part of that, Daniel, your Epsom healthcare document needs names in it. So there needs to be an organigram as an appendix. There needs to be other things as appendices, because as it is, I read it and I'm in cloud cuckoo land, I'm afraid, which is not a very good way to describe things, is it? But I'm not going to say any more. I think it needs more, it needs more information. Because how can I talk to anybody if I don't have any names?
And are you talking about how Epsom Care links into the constituent organisations? Would that be helpful to try and clarify that further?
Well, do I ask the questions now or do I leave it? I leave it, because what I've done is I have given the document to a Surrey County councillor, and I have asked him to read it blind. I don't want to have anything to do with it until he's read it, right? And then I want to have a two-way conversation. Does that make sense?
Yes, I think Bess wants to ask another question. Oh, sorry, let's go for the gentleman at the front first. Yes.
At the last month, there was a public consultation for STP in Kingston and Richmond.
Yeah.
At that consultation, they said 3 hospitals earmarked to lose the A&E. Kingston, St Helier, Epsom. When I asked them, they said they are sure that Kingston is not losing. And they didn't want to say about Epsom and St Helier. So I just want to know what's going on. We got our Merton one next week.
It seems to us, from Epsom and St Helier's perspective, that you can't run South West London without 4 acute hospital trusts. And the geography, from our perspective, works that there has to be a main A&E for the geography that we serve. Equally, there needs to be one for Croydon, there needs to be one in Kingston, and there needs to be one for Wandsworth and Merton. And that seems to us to be where this needs to end up. There was an FOI of all the programme board minutes for everything we've been speaking about in South West London, which will come out today. And in it you will see in the minutes me being very clear that I think that is, we need to be very honest with people about what the answer needs to be. It can't be what you have just said. There are far too many people who live in South West London who need quick access to an emergency department. That just has to be how it is. Councillor Ali?
Just hearing what everyone's saying, there seems to be kind of conflicting or misinterpretation of information. And I just want to know how best to resolve it, because, the reading mills are going, you're saying something, this gentleman went somewhere and he heard something different. I just want to know, how do we go about getting that consistency and that clear message? And that's what the STP should be doing, saying that and sharing that same information, and it's consistent amongst all boroughs and amongst all hospitals.
So I think it would be very powerful if the Sutton Scrutiny Committee and the Surrey Scrutiny Committee and the Merton Scrutiny Committee, who are the 3 that link for Epsom and St Helier, collectively write to 2 STPs to say all of this rumour mill about what is the future is very unhelpful, and we would like to know what the plan is, and ask for some meeting where the 2 STPs meet with the 3 scrutiny committees, and let's have the conversation in one place and see if we can land it, because it's not helpful to us either, all of this, all of the rumours. It makes it much harder to recruit staff, And we are making it harder for the public to have confidence in their local NHS. So that is what we need to happen.
Personally, I feel this is the right place for Surrey. Yeah, Surrey needs another hospital, doesn't it? Yeah. This thing, you think no, I think yes. I'm a member of the public.
Yes. So we are clear, Bob, that we serve 500,000 people.
Right.
And the geography does not really coincide with the boroughs. You know, the people live in the south of Merton, they live in the whole of Sutton, they live in the middle of Surrey, and we are their acute provider, and we wish to carry on being their acute provider. And we wanted to think of how do we get it right for 500,000 people who use us. And they live in multiple different bits of the geography, in a wide geography that has lots of council divisions in it.
Okay, the trouble is though, if there are going to be two SDPs looking after our area, we're going to be losers, aren't we?
Well, we're only going to be losers if we keep perpetuating that we're going to be losers.
Sorry, I didn't say that in this note that I wrote, did I?
No, you said
we do not want to be losers.
So you wrote a really eloquent letter for the paper that said it's time to save Epsom Hospital, and the message that we want to give is we want Epsom and St Helier, for the 500,000 people who we serve and the 5,000 staff who we employ, to have the ability to carry on doing that for years and years to come, and have a new hospital or new hospital buildings in which to do it from. So that's the stance that we are passionately taking. Now, the last question, because we're running out of time, for Bess.
What is happening to the Headley wing? What is its future?
So the Headley wing nothing is happening to the Headley wing other than it has currently got the X-ray service, the pathology service, the outpatients in it. It is the most terrible designed building. So if you're going to in any way condone the fact that if you're waiting for an outpatient appointment in Epsom, you sit in a corridor which is the main thoroughfare because there's no waiting space, and tell me that's acceptable, then I'll be quite shocked. So the design of it is awful. And we have to find a better place to put the outpatient services on this site. That either means let's see if we completely can reconfigure Headley Wing, or the service needs to move to a different part of the site. But it is really, really unacceptable to make patients wait for their outpatient appointment down the main hospital corridor.
Where are you going to put it if you're selling off lots of buildings?
So we're doing the piece of work on what is the right thing to do to re-provide the outpatient services on the site. So I can't answer the question what's happening to Headley Wing, because it's either part of a plan to refurbish it and see if we can get it to be a functional space, or that services in it need to go to a different part of the site. That's the answer.
Daniel, have you taken into account the government, what is it, 20,000 new homes built? Have you taken the account that I think the occupants will still be procreating? Have you taken into account the offspring of that first?
So yes, so in all our modelling we've done for the future in 2030, we have absolutely taken into account the fact that we have a bigger population, and the population is considerably older, and because it is older, it has a lot of different needs. And so it's no accident, is it, that Simon Stevens last week said it's time for the NHS to stop talking about closing the number of beds that it has, because you can see with population growth that you're going to need broadly the same number of beds as we have now.
Surely he's the chap that's been asking to shut them, hasn't he?
No.
He's in charge, he's at the top.
So there we go. I think we better stop on that front.
Thanks for coming. See you next time.
Thank you.